Hello, Leonard. I'm so happy to be talking with you on the This View of Life podcast. So welcome in the first place.
Thanks so much for having me, David. Again, huge honor. I'm excited to be able to talk today.
Well, I'm titling this episode "Pain is a Complex System," and I'll explain the title a little bit, and then ask you to introduce yourself as an expert in this field. But on the one hand, you'd think that an individual experiencing pain, that's about as local as a problem can get, and as physiological as a problem can get. So in order to solve it, it's primarily um, about the physical body. But what you represent is that no, the pain of an individual actually, it has, of course, some biological causes, but it also has psychological causes, social causes, cultural causes, environmental causes. And unless you take a extremely holistic approach to a person's pain, you are unlikely to solve that that problem. And so all problems are complex systems, basically. Even something as seemingly localized in an individual person as pain. That's what's so exciting about this. And and so introduce yourself as a person, just anything you want that's relevant, and then how you became a specialist in this extremely holistic approach to pain management.
No, absolutely. So yeah, I think probably, and it's funny, it's only recently kind of came into full acceptance of it, but I think this was a deeply personal journey. When I was 2 years old, I was diagnosed with chronic cluster migraines, and I was originally born and raised in South Africa, and we kind of exhausted the healthcare system really internationally, even coming into the US and across the US as a child. So really had a lot of firsthand knowledge with the limitations of the healthcare system with pain, and also the extreme impact of the cultural dimensions, the symbolic dimensions for myself personally growing up, and how it influenced my struggles with my pain. And certainly as that evolved throughout my life and different experiences. I had a number of professional sort of careers, multitude of careers, including a kind of a long-standing career in technology prior to coming into healthcare. And it took me a while to kind of come to healthcare. And my entry point, my father was a physician, my mom was a nurse, my sister was a paramedic, and I always thought I'd have nothing to do with healthcare, but ultimately kind of came back into it, and I entered into it from both physical therapy profession and a athletic training profession background. And in that journey, as I returned to the academic setting, just kind of my undergrad really kind of led me into the research realm, and realizing that was going to be a very important part of my journey, not just my clinical practice. And A lot of the elements that I gathered even in undergraduate continue to influence my way of thinking. And ultimately, between my own journey and between those of my clients, as I've started a number of organizations now, we have the Institute of Contextual Health in our clinical practice, and that we we really have come to basically embrace. I'm sometimes a bit of I get turned a little bit I get a little bit squirmish around the term holistic, and the healthcare world that tends to kind of get a little bit on the far end
Woo,
kind
woo,
of
woo.
world. Yeah, exactly. So I'm not always, and it's also from we're the Institute of Contextual Health, so our philosophy is contextualism. So for us, that's a organicist kind of perspective. So we like to say, like, maybe more comprehensive, or complex, really complex systems approach. We really do embrace
Well,
complex
there
systems.
is. Let me just stop here, Leonard, and just mark this basically as something that we can return to about this whole spectrum. On the one hand, we want to be holistic, and then there's this thing that people call woo-woo. Uh,
Hmm.
that's just like, no, not that. I mean, we want to be
Hmm.
holistic, but not that, whatever that is.
Yeah.
And then I think, first of all, I think we need to respect that a little bit
Yeah.
and not to disparage it too much. And then it brings us into the whole realm of spirituality and its many different flavors. And we'll get back to this because one of the points, as you know from our conversation just prior to this recording is just like, what's going on here scientifically is very close to the insights of Buddhism. And is Buddhism woo-woo? I think that's a
Yeah,
highly
yeah,
disparaging. So
yeah,
it goes on
yeah.
like that. But anyhow, continue with your story, especially this contextualist view, because I know that you represent the um, the tradition of applied behavior analysis and contextual behavioral science. And so I'm eager to know your sort of academic background, if you would flush that out a little bit.
Yeah, I would say again, my academic background really was not rooted in that at all. I mean, it was a very, very formal sort of allied health, clinical doctoral approach to physical therapy, and again, it really didn't have the basis of it. It was something that had to be come afterwards, and sort of in the process of clinical practice and trying to better serve a clients. And so really the journey into CBS, the contextual behavioral sciences and contextualism was kind of a postgraduate process that's come about. And there hasn't been a formal journey. It has just been really experiential more than anything else. And then
Well,
and
was it important? I don't want to attribute
yeah,
importance to it that if it didn't exist, but because I mean I look at your work and I see that it's very much within the space of um, contextual behavioral science, Steve Hayes, relational frame theory, all of these things, which will be terms familiar to some of our readers, listeners, but not others. But so what you're saying is that yes, it did enter into what you do, but no, not in your formal education. It's something that basically you acquired um, along the way. Is that what you're saying?
correct. Yeah. Yeah. It was very much something it is essential. And if I hadn't developed it, I think the framework that you and I have, kind of started to work on, collaborated on a bit has, wouldn't have existed. And again, brings us back to, again, our mutual, connection with Stephen Hayes and I wouldn't have met you or gotten to know you as well. And so I think what it did for me was this realization that, again, kind of coming back to our big thing is pain as a complex system, was this realization that the behavioral sciences, the applied behavioral sciences, and even sort of the so behavioral psychological domain has obviously had its own struggles with sort of these labels, these DSM kind of labels, as having limitations in what they actually represent on the individual level. It has almost been at a higher level. It's been built for a system, a connection of groups to communicate with some sort of shared language. However, these labels have caused a lot of issues there. I've kind of taken that and expanded it, though I'm sure I'm not the only one, that really this is the same issue we have with healthcare, where we have the ICD model, international classification, for these sort of medical diagnoses and realize that again, sort of these signs and symptoms that we've used to cluster these labels, for pain, oftentimes that's going to be your osteoarthritis, your tendinopathies, your starting to wider spread pains, your fibromyalgias, and your radiculopathies, all these different sort of labels that we've had, but they're woefully inadequate to really kind of represent the individual in front of you as a whole. And so, what that CBS world and the contextual behavioral sciences world has done for me has, number one, it's provided me ability to sort of step back and start to explore the kind of broader philosophy and that worldview of how we look at these things and how things have kind of gotten disconnected and unclear. And secondarily, given me the ability to commit to, again, pragmatism is effectively, the prototype of contextualism, and having a kind of pragmatic philosophy of science, this functional contextualism, has given me a structure, an infrastructure that I didn't have in my formal training, to be able to build and to be able to honestly embrace, this multi-level selection kind of understanding of evolution much, much more clearly. And I don't think I would have been able to do that without having a sound philosophy of science in which I could embrace some of these understandings and start to be able to look at multiple systems in a way that I can understand how they relate to each other, how they, again, sort of build on each other. And then coming into specifically complex science, embracing this idea of like emergent phenomena, these things that, not everything is going to be reduced to a single, element, a single component. That some things are require certain elements, certain substrates, but this emergence isn't necessarily going to reveal or can be reduced down to just a few things. And that really brought us back to pain, because pain is this emergent phenomena where, from a physiologic standpoint, we do need one kind of physiological element, which is we need this nociceptive apparatus within us. It's an element of the nervous system. So we have this nervous system, we embedded this sort of injury detecting or potential injury detecting system, and that is the substrate. However, what arises from that isn't enough to result in the experience of pain. Just having nociception is not adequate. This sort of danger, well, not danger, it's the wrong word, sort of injury,
Uh,
sort of,
yeah, no, this is awesome. I mean, I want to mark a couple things here,
yeah,
Leonard. This is, I love the whole conversation. One is what you've said, which I so gratifying is the need basically for a strong theoretical and even philosophical perspective behind this. On the one hand, this is a very practitioner sort of thing, but on the other hand, that we do need to philosophize and theorize about it. That's important, no matter how practical it gets. That this big thinking piece of it um, is um, is important. And then what you did was you described pain in functional terms, or what the body has is basically some system that is functionally designed, like the immune system, and I'm sure closely connected to the immune system, in order to um, signal and protect injury. But that itself is so contextual. I mean, I have anecdotes like, soldiers in getting severely injured and not even feeling anything while they're in battle. So the system is functioning as intended. This is not a time to be crippled by pain and so on and so forth. So that pain requires both a functional understanding and a mechanistic understanding. Brings us back to Tinbergen's four questions. Proximate and ultimate causation. These are key terms. So if our listeners are unfamiliar with these key terms, that's what's in store for them. But in any case, please continue and maybe begin to bring it down to earth to give a case of some of your clients as to and why it is that how they came to need your services, and then how your services needed to be beyond just treating them as a physiological organism.
absolutely. Yeah. So, again, so the clients that we serve, they range from, again, very, what would be considered more kind of acute, very obvious injury that arose, such as a sprain or a break or whatever injury may be, to more again, more complex, widespread symptoms that oftentimes get a label like fibromyalgia, or some sort of widespread sort of condition, or even sometimes get chalked a little bit into what we consider just a very much a almost kind of lack of word, but it's a little bit of like a disrespectful gaslighting kind of term, functional neurologic disorder, and things where people are just
Okay.
sort of like they're thrown in this box of what we do. You don't fit into everything. anything. And even more recently, I think what's really given us a appreciation to systems have been a lot of our cases with sort of this long COVID presentation, which prior to that, a lot of times there's Lyme disease and a lot of these things where, getting to your example, the immune system was underappreciated in the scale and the scope of how it interacts with these things. And so again, broad scope of who we see. And I would say that I think that the people that we've most again best served has been those that have been struggling for a long time, have been pushed around the system, around the country and around the world, in terms of looking for help, to even just sort of conceptualize, what's going on with them, and trying to based on that find some steps forward.
Yeah, so again, just to mark things there, and what you've already said, basically, that these typologies like the DSM and then the comparable typologies, just basically trying to put these things into pigeonholes is, and then there's a wastebasket for the things that don't go into the other pigeonhole. This is profoundly unhelpful.
Yeah, yeah.
And this is why you need something that's more process based and so on, which is, of course, a major theme that Steve Hayes is working on and that you're operating within that paradigm, basically. So please continue.
Yeah, and so again, those are coming back to some of the a lot of the work you've done with this Symbo type, and so we have sort of this group level sort of symbolic representation of these labels, and these labels are again what are accepted at the group level across medicine, yet on the individual level, again, it has very little meaning, and it can oftentimes be profoundly harmful, and so kind of coming into I would say even like a case that we've discussed might be a good sort of example, but something where there may be a knee injury, and or maybe I'll do a different case. So a knee injury, a common sort of structural change which can occur with an injury or could occur actually for benign reasons, like a medial meniscus tear. And so a tear of the knee, again, can evolve from, a twisting, turning type motion, so it can be acute. There can also be some predisposition where, again, it could manifest and it can just be sort of a normal sort of age-related change. And in one circumstance, that tear can be completely asymptomatic. It could be asymptomatic with some mechanical qualities where there might be some clicks and different things a person might perceive or some movement disturbances, or it could be symptomatic and painful. And so, kind of at the lower levels, at the substrate mechanistic sort of levels, the differentiator there is we need to start off with, okay, we got a knee, that's the region. In that knee region, we have nerves that are specifically dedicated to detecting actual potential injury. And these are going to be either active and firing and generating impulses, or they're going to be relatively quiet in their activity in response to whatever's going on in that knee. And so it could look exactly the same on an MRI. It could have the exact same diagnosis based on structural imaging and whatever, even going in there with a scope, it would look exactly the same. But for two individuals or three or four individuals, that will be completely different. Whether, again, is that nerve that's in there, is it mechanically sensitive? Is it chemically sensitive to immune molecules? Is it sensitive to pH changes? Is it sensitive to stress chemistry? So your catecholamines, your kind of fight or flight chemistry. And in which cases, again, that will present differently for each individual at the lowest level. You're going to have either generation of these impulses that are going to potentially arise as pain. So certain movements will be painful. And then other people, again, exact same structure, no pain whatsoever. And so at these very, very lower levels, we have that element. Now, as we start,
So we're still at the physiological level here. So we're basically these differences based on the same thing. We haven't even gotten to the psychosocial, cultural,
you
environmental
got it.
levels.
Yeah. There's multi-level selection that's occurring at that lower level. I mean, there's so much that has to has to be considered, and that's so underappreciated in healthcare. We are only like, oh, it's it's a medial meniscus tear. That is the diagnostic level. It doesn't, the person becomes contained to that, and even their mechanisms in their knee are not appreciated for. So multi-level selection, whether something's even going to arise physiologically, to this person's sort of experiential level. And then there's other pieces too that even at that, even if we're in that local area, we haven't appreciated what's happening at the regional area. So if you follow that peripheral nerve up, so let's say broadly the nerve we might call the femoral nerve that innervates that, or saphenous nerve, depending on what you want to go, coming to the spinal cord level. At the spinal cord level, there's a massive amount of kind of physiologic behavior between sensing and then action oriented that also generates things at the local region in that knee, immunologically, endocrine based, again, chemistry wise. And so you have a lot of sort of regional things that are happening. And then you come up to the spinal cord, the central nervous system, thalamus, brain, and you start to now have a lot of changes there that are happening just again at the physiologic level that may be affecting what's happening at that knee level. And we start to, at the organism level, we start to have behaviors like how the person is moving. Is there more muscle tension? Is there loading behaviors of that knee, how they might bend their knee and put forces through it that starts to actually make them more sensitive, more irritable. And it's happening at an unconscious level. So we're not even at this sort of like psychological level. We're still building up. And then we get up to the level of like, okay, what is this person perceiving? Their perception of this sensation of pain. How are they interpreting that? How are they putting that in context? How are they interpreting that with their ability to go up or down the stairs? Does it feel like the leg's going to buckle on them? Does that introduce fear? Does it feel, again, they can't trust it? How do they perceive themselves when they wake up in the morning? Do they feel old because of how much it hurts and how stiff they are? And so there's all these sort of like different elements that
Do
we
they become socially withdrawn?
exactly. And now you start to expand outside of the individual organism, and you start to see how the relationships start to play into it, how others look at them, how they communicate with them. With their internal self-representation versus their self versus others. How does that start to be? And what are the cultural norms, these symbolic representations that is expected of them? And that now we're not even at the healthcare interaction. And you get into the healthcare interaction, and what does the physician say? What is the
For primarily, I'm overwhelmed by the complexity. And so so after I've been just completely knocked flat by the complexity of it all, the major question is, I mean, given that all of that is true, that complexity exists, what do we do? What do we possibly do to navigate all that complexity?
And that's where it comes into again. Number one is you have to have your philosophical lens. You have to have your philosophy of science, how you're going to look at this. You have to be able to find a way to scale effectively, or manage a scope. You need to be able to have a level of precision, and you need to have a level of depth. Which again, these are qualities I'm calling
These
out
are
of the.
terms, these are keywords of contextual behavioral science.
You got it exactly. And so, if
So
we're
basically, there's a kind of a therapy that you're applying a kind of a therapy, and this is a particular problem. It's not anxiety or depression or things like that, but it's pain, but
yeah,
the same it requires the same intervention, basically. Is that right?
I mean, it's different. It's still because now we have to have new interventions. So at the first level is how do you make sense of this? So again, how do you manage the complexity? So number one is you have to the way that I've kind of described it recently to individuals has been you have these substrates, which are all the mechanisms, multiple interrelated mechanisms that are happening at lower levels physiologically, even psychologically. There are different type of mechanisms and things that are present there. Then what you have to do is you have to realize that multiple interrelated sort of mechanisms then arise again through complexity science lens and emerge. And if you look at a process of change, an evolutionary process of change, something like movement, or we might look at capacity, and we could look at physical capacity as one nature. It's an emergent, sort of phenomena of allostasis and multiple other sort of mechanisms that have sort of previously been explored. But the thing we're actually going to be assessing in the clinical setting is we're looking at these emergent phenomena, these processes of change, of which we've kind of contained it down to 9 sort of dimensions of processes of change, which allow us to be able to manage this complexity and have sufficient scope that if we need to zoom down, and we need to in the movement realm, and we need to kind of really zoom down into some of the structural elements or into some of the physiological elements and determine decisions regarding surgical intervention, regarding pharmacological intervention, including injection or other procedures. We can do that, and it's very clear to us how we can get there. But the only way we can do that is we effectively need to have these sort of emergent containers and these processes of change, because otherwise it's very, very overwhelming. And these processes of change are ultimately what we are needing to sort of explore and target when we're looking at outcomes. So we're looking at outcomes of disability, or we're looking at pain interference or different things like that. These are these outcomes. Well, those outcomes arise from these interacting processes of change. So if we're measuring in healthcare an outcome of, a certain interference of pain, or looking at disability markers, the only way we really are going to be able to improve those outcomes or target those outcomes and to understand what are the processes of change that are underpinning that outcome that we're desiring
So
to.
does this require taking like longitudinal data on single individuals, and is it inherently experimental? Is it like try this, try that, and then
100%.
so and then does ACT come into it in the sense, what are you really trying to do? I mean, it's just you trying to live a healthy life, and maybe you can do that with pain, or that sort of thing. So is it explicitly ACT therapy? And once again, I know that this is leaving behind some listeners, but I just threw a bunch of questions at you, but um, so um, um, so are you explicitly using ACT therapy? Just to start with my last question.
So again, for us, because we are primarily rehabilitation, physical therapy, occupational therapy, athletic training, speech, that kind of thing. So we're kind of in that realm. Since most of us did not have a primary psychological training, ACT was an easier entry point for us. And so the one part is ACT is again this model, which is really representative of psychological flexibility processes of change.
Yes, yes.
And so these psychological flexibility processes are very, very essential to us. There were 6 of the 9 sort of processes of change that we are interested in interacting. However, they're not the only element. We added again 3 different elements related to movement, capacity, and social relational processes that are very, very important for us to explore as well. Now, we do always have this psychological flexibility element that's part of it. However, we are still very much interested in again, if there are elements that we can change, if there are processes of change that we can engage in, that we can target, that again address these physiologic substrates such as nociception, that we can reduce pain. That is our primary concern. Is
Sure.
can we make influence on this? And oftentimes, again, it's indirect. We're trying to figure out what are the systems and the elements that are part of what are sustaining nociception, which is this kind of injury sort of impulses, so to speak, or injury sort of signals, which is still wrong. Nociception again is sort of like this compacting of these nerve impulses that are primarily along pathways related to actual potential injury. And so we just want to figure out, can we somehow remove the fuel off those pathways? Is there a possibility for us to do that? And that can range from, again, physical interventions, which we really focus on physical behavioral change. So instead of a kind of non-specific exercise for the knee, where we're working on, bending the knee, straightening the knee, range of motion, strengthening, those kind of things. Those may play a part and sometimes are important, but we're more interested in where does that knee pain show up? Is it going up the stairs, down the stairs, getting down and up off the ground, and sitting? So we look at the physical behaviors. And it's one of
So
the papers that Madhur Mengalam, who's kind of been part of this process of getting this paperwork, and he was kind of part of, with the collaborative paper that we've been working on. We're doing another paper now where we're looking at sort of multi-scale analysis of movement, where we can objectively look at through 2D and 3D dimensional analysis, as well as maybe with movement tracking, some of these behaviors that we are seeing in the clinic, that we are trying to create variations of those, again, using variation, selection, retention strategies. Can we create a variation? Can we figure out, whether that individual is able to have their system select on it? And then what do we need to retain that behavior long term?
So you do think explicitly in terms of what I call VSR cycles, variation, selection,
100%. Yeah,
retention
yeah,
cycles,
yeah.
operating at multiple scales. So I mean, even at the purely biological scale, before we get to other layers, then that kind of thing is going on.
Exactly. That, I mean, I would say if you were to describe our intervention, it's variation, selection, retention. That's kind of where our interventions are. We're just trying to determine, at what level are we trying to do that. And so it is not a purely psychological flex, a purely act. Those elements are 100% necessary to be sort of around all of it. However, so oftentimes they are playing a supportive element, but then other times they are the direct thing that we're focusing on at any given point. Um,
Yeah, I can see that. I think you explained that very well. Um, can you give a kind of two things? First of all, some more cases basically of people who have been helped and exactly what worked for them in those cases at any one of these levels, and especially a level in which actually uh, uh, the solution was in the kind of psychosocial cultural realm. Um, although cases in which the solution remained in the physiological realm would be fine also. And then to do the same for published studies, because I mean, what's the evidence that this holistic method uh, works? And I do believe, I mean, this is in some well enough studied, so there's now a literature on it, and we can say not only do we have theoretical reasons to expect this approach to work, but we have evidence that does work, and so we're far enough along so that it's not just future tense as to whether we're not dreaming this up. I mean, there's a track record. So let's begin with some stories of individuals and then proceed to hard evidence.
Absolutely. Yeah. So, let's do let's do a good complex one, and then we'll come back to a simple one. We already talked about the knee pain. Let's say like a case in which kind of broad set of symptoms, effectively sort of multi-joint pain, and kind of had gone through the healthcare system. I mean, I would say if I'm thinking about this case right, they probably had 27 different healthcare provider contexts up to the point of when we saw them. I mean, that's just probably an underrepresentation of how many different physicians and other providers that they had engaged with over a 20 or 30-year period. And so again, accumulated many labels along the way. Ironically, some of the ones that they didn't accumulate were probably essential to the ultimate solution. But again, multiple, osteoarthritis, multiple articular injuries, hip labral tears, and then kind of scaling up to uh, systemic like fatigue issues, a lot of skin issues, a lot of different things that were presenting. And Up to this point, again, immunologically, whenever their blood was tested again, the markers for inflammatory processes were negative, and a lot of sort of looking at some metabolic things or looking at some endocrine things. Nothing came up. They did have a long history as a female individual with endometriosis, and so a lot of again different scales of systems that were operating in this case that was clear that there was some physiologic and multi-system involvement, but because none of the labels really fit, they never got a formal diagnosis of anything. It was just kind of a clustering of things. Had gotten to the point of, again, being relatively disabled, relatively was not employed, was not doing a lot of work, and effectively when they came to us again, they were at a pretty low period of their life. And, they felt pretty much like number one is they started to feel like they were imagining it. So what we did was they were at a lower level of sort of activity. They were disengaged from family. They were disengaged from community. They were no longer involved in work. As we took again a good systems-based sort of perspective of everything that was showing up from again sort of medical history base, and we looked at their community, their status, and how they were sort of operating there, and we formulated with them, where we are now. And we started to sort of, again, used a lot of this act-based psychological flexibility to clarify what's important to them. That's a lot of times, again, in these, when we're at the lowest level, we need to start just figuring out what's even important, identifying the things that brought them joy in the past or energized them. And as we start to identify some of these values and start to realize, again, they liked education. They like to teach people new things. They like to learn new things. They were very family oriented, but weren't quite as actively involved in their families they'd like. We would then, based on that, between the physical therapists and the occupational therapists, and in this individual, they had had some intermittent counseling and psychology over the years, and initially were a little hesitant to re-engage in counseling. We did bring in a counselor later on as they came a little bit more comfortable, but it's primarily the physical therapists and occupational therapists who guided this process. But effectively, what we did is we started to, again, create these small sort of action steps along the way that were values oriented, to be able to start to create a little bit of engagement in life, and start to, again, bring in these social
Just quality of life in general terms.
You got it.
Yeah.
And then at the same time, we started to explore, what are some collaborative providers? Were there some providers who were willing to kind of, again, experiment with medications that other providers weren't willing to do because they didn't fit in the box. And so we started to sort of help them with collaboration with physicians to start to explore some different medications based on what we were doing with the systems analysis.
This is an important thing here, and I'll return to it later on. But the idea that in order to do this, you have to bring the stakeholders together. If there's a whole system approach is required, that whole system is going to have all these agents and stakeholders, and they have to be assembled and coordinated. That's exactly what you've said. So it's not just you and your client. You have all these other relevant stakeholders that you can draw upon contextually. You don't know exactly which one you'll need to draw upon. And so you have a system level of organization, and then that is trained upon each and every case in a highly contextual fashion. That's why context is such a key word. But that's just a summary of what you've been saying. So please continue.
Absolutely. And so then again, continued on with our sort of movement, sort of skill-based experiments, and trying to effectively have this person understand their own skeleton, their anatomy a little bit better from a movement perspective,
Okay.
along with some of the medication changes, along with the sort of value
So you don't shy away from medication. I mean, meds
Oh,
is one
yeah.
thing is a tool in your, is a quiver in your, an arrow in your quiver.
Yeah,
So,
well, we certainly like to delegate that. We really like to delegate. I tell people there's liabilities that we all take on, and so I'll delegate those liabilities to the person who's got that license behind them. I just might have a little bit. We're sort of this case manager role. I mean, to a large degree, that because we can look in complex systems, we can kind of pick out things that that might not have been caught, then present it in a way that the person who has that ability to bring in that medication or that injection or that surgery, even that, I mean, we don't shy away from any of those things if it's contextually relevant, if it actually.
and in each case, you're monitoring it, so you know whether it works or not. And I mean, contrast that with with the typical healthcare system where you go and they just your records are so incomplete. I mean, there's just none of that close monitoring. So monitoring is huge here, it seems, and unsurprisingly. But I mean, it's shocking that it doesn't take place
No, oh
usually.
yeah, no.
So
Yeah, which is again, this is at a system we're talking about, CAS 1 versus CAS 2. Again, looking at the healthcare system, it's like this clustered individual agents that don't operate well as a system. And so to a large degree, what we're trying to do is develop like how does an actual CAS 1 look like in a community?
yeah,
Um,
for our listeners, the code is CAS1 is a complex system that functions well as a system, and CAS2 is a complex system composed of agents pursuing their separate adaptive strategies. And we need CAS1 systems. We're stuck with CAS2 systems, and so the whole challenge is to evolve CAS2 systems into CAS1 systems, just to explain that terminology. But continue.
silly. Yeah, so long story short, in this case, again, complex multiple systems, multiple providers that we had to bring in, trying to operate as a CAS1, as one unified sort of system. We were able to get this person back into a meaningful career, better engagement with their family, back in social systems with their friends. They experienced periods of actual pain relief. I mean, that was probably the most profound thing. They'd been had not been pain-free periods in their life. Now, again, we made it clear to them, like, this isn't, I mean, it's a large part of your system. It's going to arise and they would have flare-ups and episodes, but they were able to have periods where they were relatively, pain-free and highly functioning. And how do we make it sustainable? I mean, that's a big part of also what we're interested in is we're interested in sustainability rather than episodic base, which is what healthcare is really oriented. It's like you have an episode, we fix it, you're done. Well, reality is like nothing that's in the system is ever going to go away. It's like it's still a part there somewhere and it might arise at a later point in life in some way. So you have to develop a sustainable process, skills and connections and support to be able to.
Does that involve having like a continuous relationship with you? And again, all of this is generalizable. When I'm operating in the business sphere, I'm saying, no, I'm not going to do some in and out consultation with the business. I want to have a permanent relationship with the business because cultural evolution never ends. And so that's how general it is. But I imagine it's a little bit hard to implement just in terms of who pays for it or that sort of thing. So how do you actually try to establish a continuing relationship given the realities of the healthcare system and insurance and payment, and the person might not be in a position to personally pay out of pocket for something like this. But this is another case where you really want the whole healthcare system to be set up for that, so that that wasn't something you had to work to do. That was just part of the DNA of the healthcare system. But that's a utopian view.
Yeah, no, we've pretty much kind of abandoned utopia pretty intensely. We just kind of realized that we are to some degree, again, we have to exemplify it ourselves, but we have to find a way to make it sustainable for ourselves. So yeah, we intend to have permanent relationships with our clients to some degree. Some people it's some basis monthly, quarterly, 6 months, year, every few years kind of thing.
So a checkup, kind of a yearly checkup.
You got it. So very much the kind of like primary care model that's supposed to be working, and has worked in some instances, but it's been a struggle for primary care to really work in the healthcare environment. But to some degree, again, we've taken that at this level from sort of musculoskeletal health and pain health, kind of or pain-related sort of conditions. Like, we are this long-term continuum as long as the person is willing to be and able to be a part of that. And a large part of that has been really what we spent the last year. We always knew we needed to do this, but after we had a lot of failed attempts to get funding, we just decided to develop it ourselves, which is the technology. And so technology, I think, is going to be really the only sustainable way to case manage and to serve individuals across a lifetime in small groups like ourselves. I think that it's going to empower us to not have to depend on the larger groups, and to be very adaptive to the changes of what the larger hospital entities and payers
So
and things.
describe this technology. I think it's similar to what the kind of thing Steve Hayes is also developing. Is that right?
You got it, absolutely. So, again, what Hayes's group is doing with MindGrapher and with some other elements, where how do we longitudinally track? How do we provide education interventions for maintaining things over a lifetime? That is again a very similar one that we just sort of expand beyond the psychological flexibility realm into, again, movement, into pain, into all sorts of other symptomologies and things that present. And so there is an element of, again, a system or a data ecosystem that we are developing. And then there's different front ends to that are very app-like, that are sort of adaptive to the individual. But the way that we're currently taking it is that it's not going to be an app that we put out there just by itself and people will be able to have, download it and have like an AI that coaches them. We still are trying to get this sort of human in the middle, which again, right now would be our providers, and we hope it'll be other people who'd be willing to do this in the future. But effectively, coaches, preferably again, licensed sort of healthcare individuals who are sort of in betweens plugged into this data ecosystem and able to sort of manage the tools that are on this kind of individual's device, that is a part of their long-term sort of journey, and assisting them with basically taking intakes and periodic check-ins and exploring interventions and exploring needs.
Okay. Okay.
When
And
things.
is the experience sampling method part of this? Are they actually signaled
Yes.
at random times? And so you got a continuing longitudinal, real data of, and for example, are you experiencing pain right now? And
You
so
got it.
on.
And then what are the other elements that are present? So it's a full ecological momentary analysis kind of thing. And then some specifics on the process of change, again, that Hayes, and Siriachi and Hoffman have really been developing. So some of those pieces, and it's still early. I mean, again, you talked about the research, and just to kind of momentarily pivot into that is like,
Yeah.
we have elements of this, and there's clear evidence that some of the assessments and are there, and we have intervention like studies. So we have again, we have a lot of good stuff from trying to think through Sadra and the Sunstrom, and I think who was the other group did some really good. I can't remember. I'm trying to actually scroll here. I can't pronounce his last name, but Sanabria Mazo. They had done some really good job with like some of the idiographic and then idionomic sort of assessments, and seeing how important it is to, again, not use a lot of these group level normative sort of labels to try and cluster back pain, fibromyalgia, different types of conditions. So there's these initial sort of studies on assessment that are and evaluation that are showing this need for this individualized sort of kind of assessment evaluation, and then the need for that longitudinal data. And then the closest thing we have now to the interventional realm is from Peter O'Sullivan's group, which they do what's called cognitive functional therapy. It's very much built on more cognitive behavioral therapy, so less act-like. And so they again, and they to some degree, they sometimes call it mechanisms of change, so a process of change, but they're kind of on the same journey. It's just, again, it's just a more of a philosophical differences between our group, but for the most part, we're doing a lot of the same things. And so they've really had some great data outcomes over 5-year periods with low back pain, showing again, not only these sustainable sort of benefits with these chronic back pain cases, but and ongoing sort of improvements, but also being able to break it down to, again, they called it like the mechanisms and specific sort of definitions. And again, seeing a lot of the psychological and social factors being, in many of these cases, the primary sustaining sort of processes that are maintaining these chronic back pain episodes. So they're able to do sort of these retroactive analysis. And so we hope to do the same, but again, just with our philosophical bend and a little bit broader scope. We're kind of looking a little bit bigger than where they might be looking right now. So.
Well, let me wrap up with there's a few points before we wrap up. I'm so happy to have made this recording. I want to give two examples that are completely out of the uh, health field to illustrate what's so general about this, and then return to your institute. Um, and then to finish up, actually, I'm making a connection with Buddhism as we as
Oh,
we
yes. Yeah.
as we as we talked about. But so one is a solution to homelessness. It's an organization called Community Solutions. It's led by someone named Roseanne Haggerty. And the approach, which is working very well, thank you very much, is she received a MacArthur Foundation $100 million grant. That's how successful she is. Um, and the approach is, in the first place, to assemble all the different stakeholders, all the different organizations in, let's say, a county or a city that might be needed to address the problem of homelessness. And so there's your system level approach. And then they train that on each and every individual homeless person. And so the problem here is homelessness. It's not somebody's pain, it's homelessness. But the same principles are operating. You need a systems level layer to it, and that needs to be trained very contextually on each and every individual case. And so I think everyone can see the similarity with what you're doing. My second example is in the city of Boston, um, where the problem here are various forms of disruption, such as crime-ridden neighborhoods and or crime or drugs or things like that. And one point, this is work of Dan O'Brien, who happens to be a former student of mine and who runs something called the Boston Area Research Initiative, which is a consortium of universities that advises the city of Boston. So it's this system level thing again, right? And so one of the points he makes, which I think is lovely, is that typically in urban research, the neighborhood is the basic unit. And what Dan wants us to know is that many problems are actually require a higher degree of granularity than that. It's actually not the neighborhood, it's the street or the single property. And if you don't understand the right scale, then you can't get started. So first you have to identify the right scale. And then let's say it's a property, if there's one that's identified and as, clearly a problem, then this unit comes in and puts the property owner on notice. And it begins with a conversation with the property owner about this problem. It doesn't start out mean or hostile or anything like that. It's collaborative. But of course, the problem does need to be solved. And if the landowner, property owner is indeed negligent, then it's on that person to fix the problem. So once again, we have the systemic and the case, the systemic and the case. And so against that background, I think, as you've described your institute to me, it's broadening out beyond the specific topic domain of pain management, employing the same uh, uh, basic technique. And please describe your institute. And I think, and hopefully I've provided a good introduction. Correct me if I'm wrong. But what you're trying to do with your institute, which includes but goes beyond the specific domain of pain management.
Oh yeah, no, that's perfect. Those are super helpful, and again, just kind of yeah. Again, reminding us, we're not alone in this journey. Sometimes you feel very isolated, obviously, and to see it in a different context is huge. Yeah, so we are again the Institute of Contextual Health. We're a 501(c)(3) nonprofit. We have four programs. The clinical side we've kind of discussed, and the research side and the technology side. We also have the educational side that's present here, and to us again, it's essential that we have again all four programs to be able to again address the complexities of human health and wellness and fitness wherever you want to enter in from this. And so it is a lot broader than pain. Pain was, to be honest, was a matter of convenience. My own background, my own sort of kind of entry into the system as in my profession, and uh, again, so sort of pain and sort of the musculoskeletal sort of which again is to me is a poor representation of movement and pain, but sort of I guess in the healthcare world we'll say the musculoskeletal sort of realm is sort of our starting point based on convenience. It is something that we are most exclusively trained in, and again, we have the ability to do a lot of impact because it's such a large part of the healthcare cost. In fact, it is really the largest expense in healthcare. So we can do a lot of good just even staying in that world. That said, again, as we talked briefly prior to this, we are seeing that we need to expand that. The world of rheumatology again is huge, and I think it's going to be in the sort of medical discipline.
Can you describe that world for, I mean, everyone knows the word rheumatology, but
Yeah.
what does it mean?
Coming back to the earlier example you gave, that is that world of the immune system applied in particular to, particular to the skeletal system to a large degree. But it's much broader than that as well. So it's a subset of the medical discipline that looks at how do we look at the immense complexity of the immune system in relationship to, again, particular musculoskeletal conditions, but bigger than that as well. And so it's an actual sort of bridge for us there. And again, so many of the cases that we're seeing, the immune system and the nervous system and the endocrine system or the neuroendocrine immune axis is sort of like a central sort of pillar of understanding for us for the all of pain, all of movement, and for us to have that medical collaboration. And how are we going to explore that pharmacologically? How are we going to explore, genomics, epigenomics, proteomics, all these different sort of scales of data that we can collect and explore and see how does the exploring those substrates, those mechanisms impact these processes of change that we've developed so far? And do we have to identify new processes of change to sort of represent these in the clinical side? So yeah, there's a whole world there that we're just starting to touch into. And then kind of coming back to that case management and general health, I think the dream and the vision is for us to look at, how do we take this approach and we bring in, general practitioners, the primary care physician world. And it's just, I'm thinking, 10, 20 years down the line, but, the mission and the vision is how do we take this contextual sort of worldview and apply it to human health in the most practical way possible to make the most change and reduce.
Yeah, just imagine. I can speak to my own experience. I belong to a family health practice in my little town. I mean, my God, it is just so. deficient in everything that we're talking about. No, I mean, it's average. I mean, I'm not saying it's that, I mean, that's what makes it even more shocking. It might even be above average.
Absolutely. You never know,
But,
honestly, because
but it
it's
is
so
just like,
fragmented. It's,
but it's
yeah.
just like so bad. And you know, if there's another model such as this one where you go and you establish something close to a permanent ongoing relationship, and then you get this kind of contextual care, oh my God, I mean, it would be so much so much better. And then you know, multiply that further up the, it's always still the individual is the point of entry. The individual, and then a lot of this is the fact, I think, that to step away back to the very broad philosophical um, level that you know, we could call Western culture during the 20th century and before was the age of reductionism and individualism. It almost defines Western uh, society. And now I think, and there's a whole other, you know, podcasts and stuff to write about there, that we really are entering a age of holism and relationalism, in part based by scientific developments like the advent of computers. You couldn't study complex systems scientifically without the advent of computers, and so they weren't widespread until 50 or so years ago. Generalized Darwinism is new. Darwinism was only constricted to genetic evolution. Now it's so much broader. So we have all these new ideas. Um, and yet, if you now step outside of Western culture, you find that they've been holistic all along. And that includes not only traditions such as Buddhism, which we'll touch on again, but indigenous traditions are inherently relational, and Asian traditions. Famously, people like Dick Nisbet, there's a whole literature on Western versus Asian thought, basically, and how Asian thought is so much more relational than Western thought. So we're kind of playing catch up with our scientific tools and so on. And with respect to Buddhism, uh, just to touch upon it, I think it's inherently systemic. It does recognize suffering basically as inherently a systemic process, that the self is not really the self is a node in a much more complex system. And it's been nourishing people and communities for thousands of years. And so please make your own connection with Buddhism or any other spiritual tradition. And against that background, I think we're really to make fun of what gets called New Age is really mean-spirited on our part if we were to do that, because here we have people that are reaching um, for that, and they're our friends basically. So at the same time, there's a strong need to be science-based, and so if it strays into the area of just being detached from factual knowledge, then that is a problem, of course. But say whatever you like in closing, Leonard, about the connections you see with traditions that long predate uh, the age of individualism and reductionism in Western thought and science.
Yeah, it's my mind just kind of went in a lot of directions as as you were introducing that, and so I'm trying to rein that in a bit. You know, one of the things again, kind of coming back to it, and you're right. You know, it is very easy to just sort of negate the importance of what has come before, in particular when we're looking at these bigger picture sort of lenses. And again, for myself, I would say again, from a spiritual sort of tradition, you know, again, having gone through sort of this, you know, early on growing up in more of a uh, traditional kind of Christian kind of background, and realizing again some of the spiritual elements, particular in the mystic sort of side of Christianity, that Christian mysticism. very, very much being an important part. And then again, expanding into Buddhism and looking into a lot of these kind of Eastern philosophical as well as spiritual sort of dimensions has been an essential part, again, of my growth and development. And I think in recent years, again, the sort of reconciling between the science and the spirituality has really been that it is the same. And in fact, I think the only thing that I always kind of caution and my fears are sometimes is making sure that we're taking an inventory of almost is the same thing with pharmacological different things like that. But what are some of the specific, non-specific, and adverse events? Because there are risks in some of those traditions too, with again cultism and different things. And again, those are deviants off the actual bigger picture, as well as again spiritual healers and different things that sometimes have constrained people's opportunity for real health change and improvement by being very stuck and sometimes have very been harmful, in addition to again very abusive sort of spiritual relationships. Curiously, again, if you look at even some of the Buddhist monistic sort of practices, the interesting thing about that sort of there is this very individualism actually process. It really is back to the individual, to be honest.
Yeah.
Hence going into the cave or going into the monastery, there's a lot of self-development, and in
Yeah,
some
absolutely.
cases, the curious thing is that it stays there and it doesn't necessarily get out in the community. But there are many efforts and many monastic traditions that have a very deliberate intention to still have the monks out in the communities and so on, and people who left the monastery and went out in the world. And so, ironically, sometimes for being a very sort of broad-minded, it had become a very individualistic, sometimes practice,
Yeah,
even
and
tradition.
narcissistic, especially in the West, narcissistic, basically.
Yeah,
So,
absolutely. Yeah.
for-
But even in the East, again, people who just isolated themselves and never came back out, their individual growth became that central piece. And and so there's been a little bit of that to keep in mind. Now, taking that bigger picture, to me, again, this broader kind of lens, this interconnected lens, again, I've started to had to find a way for me to look at that even from a contextualistic perspective. It has been very, very helpful for me to look at things like what you guys have explored with, like, you're looking at the noosphere and looking at symbotype and looking at these different things that are representative of this broader kind of spiritual interconnectedness, which again are rooted in many of the traditions, especially when the traditions are done well and don't become disruptive. Um, it really is kind of a vision of what could be possible when we appreciate and we tune in to the bigger kind of lens. And it would be interesting to even say to explore things like ideas like traditions of karma, having some relationship with the idea of causation. It's sort of like there's similarities to some degree, like, is karma just causation, or, there's a whole layer there. And so there is a lot in that spiritual kind of tradition that can inform us and inspire us. And I think that there are aspects that, left well enough alone could just be used. And I think there are aspects of it where we can evolve and really find new, more practical ways that do work better at this multiple levels, so that it's that individual and the group and the group and the individual. Like, how do we not make sure we're just not having everyone crawl into the mountain and just going on that personal journey. I mean, the reality is we again, kind of coming back to tradition, the idea is you transform for others. And if you don't take what's in you and transform that, you transmit it, kind of thing. And so how do we make sure that we find that balance? But then again, also, how do we also make sense of individuals who have a hard time, and there is a cost to being out in the community, and maybe some of these traditions of spirituality had naturally appealed to individuals who had social had developmentally at different levels um, challenges with social interactions that they were in fact to some degree, for lack of a word, they could be painful and they were exhausting. And how do you manage these individuals that have in some traditions been called introverted versus extroverted, and bringing that back to how has that played into the spiritual journeys of connectedness, where the individual is, it's like that wave that arises in the ocean and then dissipates. Is it just that? Is it just that momentary emergence of that individual, or is it this group of waves that are a part of this ocean over time that are representing a moment in time, and how could they um, arise in that moment of time to most meaningfully impact the world around them. So yeah, I'm kind of deviating a little bit, but one of the more interesting things for me, and especially from our kind of institute, is again coming back to complexity science is looking at consciousness, looking at the universal consciousness type ideas, and all these different things. That there's clearly some sort of emergent phenomena where each individual is an emergence of what has come before and what is. Much like these analogies of the wave that's just here for a moment and then gone, it's part of the whole. Yeah, I think there's such a massive kind of element of that that's underpinning what we're trying to accomplish. But I think we're still trying to figure that out, because it's very easy you know, to get that loss in woo-woo that's disrespected and not appreciated for its value and its meaning for humanity. So
Yeah, that's great. I really loved and agreed with almost all of that. And once again, it's illustrated that what could be better than to be um, having this kind of philosophical discourse and spiritual discourse, and at the same time, uh, uh, helping alleviate pain. So it's immensely spiritual, philosophical, scientific, and it's immensely practical. That's what we have in front of us. And so and I'm really happy to have captured this in this recording. If you look at some of my other podcasts, you'll see the same things at play, but in very different venues. And so, and of course, that's part of it, that's how general it all is. And so, all good. I wish you the very best, and I really want to stay involved there, and to see this unfold and in your place, Grand Rapids, Michigan, right? And so I'm thinking every location can become a location for this and can spread. You're spreading it in your institution, but still mostly within, I mean, when you described what you're aspiring to, entering the general practitioner realm was your ambition. And that would be just so awesome and so huge. But then there's so much more beyond that. And it's not for you to do that. But just imagine that for anything else having to do, let's say, education, um, business, or whatever, that this could be taking place, and it could be taking place at particular places, then that's where we can begin to think about the formation of metropolitan hubs and things like that, all employing the same basic basic approach. So that's what we're working towards, and we took a nice step in that direction. So thank you so much.
very, very much appreciated. Thank you for the time, and yeah, no, greatly appreciate our connection.